Good morning and welcome to the Minnesota Reproductive and Sexual Health Update hosted by Healthcare Education and Training. My name is Jen Stevenson and I am the Director of Business Operations and I will be facilitating the training today. Let me briefly introduce you to Healthcare Education and Training. Our mission is to provide comprehensive program development, education, and training to improve reproductive and sexual health outcomes. HCT is an organization of passionate people who are proactive in their belief that access to evidence-based, medically accurate reproductive and sexual health education, training, and care is a fundamental right. This event has closed captions available. To enable them on your screen, click Live Transcript at the bottom of your screen, then click Show Subtitle. You can change your accessibility settings by clicking Subtitle Settings. For more information and to keep up to date with HCT events, please be sure to follow HCT on these various social media platforms, visit our website, and check out our virtual learning opportunities. Now I will quickly review some housekeeping information. Each session today has a unique Zoom link, which can be found in the agenda. A link to complete an event evaluation, including today's handouts, and the Nursing Contact Hour form will be sent to you via email following the update. Your feedback is greatly appreciated. Archived presentations and a list of upcoming events can be viewed on our website. If you have any technical difficulties during this presentation, please contact Kelsey at khungerford@hct.org. If a presenter has any potential or perceived conflict of interest, they will disclose them at the beginning of their presentation. We would like to thank our co-sponsors for their commitment to the Minnesota Update. We appreciate the support from the Minnesota Department of Health, Child and Family Health Division, Maternal and Child Health Section, and the Prevention Research Center. We would also like to thank this year's Planning Committee. We appreciate the time they give to ensure that the Minnesota Update is a success. There are nursing contact hours available for today's event. If interested, please complete the nursing contact verification form previously emailed to you. We will also make sure to include it with the evaluation email. You are encouraged to ask questions throughout each presentation. To ask a question, please click Chat or utilize the Q&A feature and type your question. Questions will be answered at the end of each session. Now I would like to introduce our opening keynote. Dr. Anu Gomez is Associate Professor at the School of Social Welfare and Director of the Sexual Health and Reproductive Equity Program. For more than 15 years, Dr. Gomez has worked as a health equity researcher with a focus on reproduction and sexuality throughout the life course. She has conducted research both in the US and globally on diverse topics, including contraceptive use, abortion, HIV prevention, gender equity, transgender health, and violence against women and children. Dr. Gomez's current research focuses on 3 areas: the measurement and meaning of pregnancy planning, understanding contraceptive decision-making within social, relational, and structural context, and evaluating the impact of and evidence base for policies related to reproductive health. She currently collaborates with researchers at the University of California, San Francisco, the Guttmacher Institute, Planned Parenthood of Northern California, and California Latinas for Reproductive Justice. Without further ado, I will pass things over to Dr. Gomez to kick us off.
Good morning, everyone. I am coming to you from the land of the Ohlone in Berkeley, California this morning, and my pronouns are she, her, and hers. For disclosures, I am currently receiving research funding from Genentech for the Abundant Birth Project evaluation. And I would like to acknowledge the funder of some of the research I'm going to present, the National Institute of Child Health and Human Development, as well as my collaborators, Stephanie Arteaga and Bridget Freehart. So today, my goal for you is to really think about how to understand reproductive autonomy and coercion from a multi-level perspective, but also really to be able to think about how that translates to the clinical environment and people's contraceptive decision-making. So I wanted to first just start with some definitions to get us, well, to at least let you know where I'm coming from. I'm not sure that means we'll all be on the same page, but at least do a little bit of level setting. So the first is reproductive autonomy. And so I really like this definition that was put forth in a paper by some colleagues from the University of Wisconsin-Madison and talking about reproductive autonomy in the COVID-19 pandemic. And so they define it as individuals' ability to be fully empowered agents in their reproductive needs and decisions, and to access reproductive health services without interference or coercion. I like that this definition doesn't explicitly focus on pregnancy prevention, because we know that there's much more to sexual and reproductive health and reproductive health services beyond contraception or other pregnancy-related services. And it also highlights that interference or coercion are barriers to reproductive autonomy. So what is coercion then? I wanted to uplift that the specific term reproductive coercion is typically used to describe interpersonal coercion in the context of intimate relationships. And so I hesitated. I haven't even titled this slide reproductive coercion because once a term is used in a specific way, it's hard to change that meaning. But I do think that we have to think about coercion in relationships, but beyond relationships as well. And so another related concept is contraceptive coercion. And this definition comes from the American Public Health Association policy statement in opposition to coercion in contraceptive access and care, which I worked on last year with colleagues from the sexual and reproductive health section. And so we offered the definition of contraceptive coercion as any attempt to influence or control someone's access or ability to use or not use contraception as they wish. And so if we were applying this specific, this definition around contraceptive coercion to the broader context of reproductive health, I think we would think about this in terms of replacing, to use or not use contraception as they wish with reproductive decision-making. And I wanted to offer that alternative framing on coercion because I want to emphasize that coercion and autonomy are both facilitated by systems and structures, as well as interpersonal relationships. And these are things that are happening within individuals, but they are produced by different levels, different structures, different policies. So if you have any training in public health, you've probably seen this before. These concentric circles are representing the social ecological model that thinks about the different levels at which health is produced and hindered. And so I wanted to take the opportunity to go through this framework so folks can start to think about the roles of healthcare professionals and institutions in reproductive coercion and autonomy. And so I'm going to start at the interpersonal level. And so this is meant to represent someone talking to a provider about contraception. But this could represent anything. I've chosen to use this to represent a person-centered contraceptive counseling experience, one where a person who is seeking contraception or considering it is valued and listened to and is provided information that helps them make the best decision for themselves, whether that's using a LARC, whether that is using condoms, or whether that's leaving without a method because the information provided really illuminated that was best aligned with that person's values. And so I want to think of this as autonomy being facilitated in interpersonal interaction. We could think about this within families, right? There's all types of interpersonal relationships, but thinking about having autonomy being facilitated by open conversations about sexuality, support for young people's desire to use contraception, to have the information that they need to best, determine their safety, their pregnancy plans, et cetera, is another way that autonomy could be facilitated at the interpersonal level. But of course, coercion can also be facilitated at the interpersonal level. There's always the flip side of, you could have told us a different story about either of those photos than I chose to. And so I always, I go back to this example of Britney Spears not being able to get her IUD removed because of her family's desires around, around controlling her, as an example of how coercion is happening at an interpersonal level. There is also, what I was mentioning earlier about partners, reproductive coercion within partnerships. And so, sometimes this is called birth control sabotage, but there's also, the hiding of pills, the piercing of condoms, or stealthing, which is, removal of condoms without someone's consent. Those are all ways that coercion is happening within interpersonal relationships. And then, and then of course this can happen within, the context of a clinical interpersonal interaction. This is just actually a very recent story about someone who has been denied IUD removal by, I believe at the time of the writing of the article, it was at least 4 providers over the course of a year. And of course, it's complicated. The IUD is embedded, and so it's not as easy as pulling some strings. But at the same time, she still hasn't been able to find someone who will take this out over the course of a year. And so really that is, essentially being forced to continue to use a method when she doesn't want to. And so that is something that we can think about as being coercive. So moving through these levels, we could think about the organizational level. I think it's important to think about policy with a little p, as health policy people or other policy people might talk about. But really, obviously there's the policy with the big P, like legislation, Supreme Court decisions, but then there's also policy with a little p, which are protocols, procedures, organization rules, administrative rules, incentives, disincentives that may be going on within a clinical setting, a healthcare system, et cetera, that can both, again, I think about coercion and autonomy being 2 sides of the same coin. A protocol could facilitate coercion, or it could facilitate autonomy. It could potentially be neutral, but really often things that are seemingly neutral may not end up having that effect. And so I, for example, when I was first started doing research on IUDs and implants and people's decision making around them, I heard about, it was a place in Northern California where people apparently informally knew that they weren't able to get their LARC removed if they wanted to get it removed within a year of insertion. And I'm not sure if this was a formal rule or an informal rule or whatnot, but that sort of, they knew they had to go to a different healthcare setting if they want to get it removed earlier. And so that is a norm or a rule that's really actually facilitating coercion, whereas, a lack of a rule or a support for people removing their, switching contraception or stopping contraception as a cultural thing is also a way that autonomy is facilitated. And then, there's, these circles, they really intersect. I think things that happen in organizations are often determined by policies or funding requirements or whatnot. And so I have for this one, coercion and autonomy at the organizational and the public policy level. And so I think one way this is relevant is performance measures for contraceptive care. This is a wonderful article by my colleague, Christine Dellendorf, thinking about when we have a metric around contraception, what is it capturing and what are we intending it to capture? And, I'm sure that many of you are familiar with the Office of Populations Affairs quality metrics around provision of long-acting methods. And, I think often both there and in things like healthy people, the healthy people goals put together by the Centers for Disease Control and Prevention, you see things like % of people using, some types of methods, highly effective methods. That the definition of what that is could vary, but those are, but it's really just a sort of a binary thing. Is someone using a method or not using a method? And that is a signal of quality or of achievement of goals or whatnot. But that those things don't actually maybe reflect the needs and values of the people who are using contraception or want to be using contraception. And so that's a way, again, that coercion could be facilitated or autonomy could be facilitated. I recently came back from Society for Family Planning conference, and I heard someone who's a clinician from New Jersey really bemoaning the requirements of the Title X program around metrics and around the things that, you know, she had to ask her patients as a condition of this funding. And so there, you know, obviously that's something that she is having to implement at a level of clinical counter, but it's really coming down from, you know, higher levels that value is being perpetuated. Of course, you know, policy can facilitate autonomy in many ways, and this is just thinking about the implementation of the Affordable Care Act and the, you know, removal of cost sharing for contraceptive care. And so that's, you know, something that happened at a policy level and increased access in many ways, and especially for certain methods and the full range of methods. And so there are ways that policy could really support autonomy. There are ways that it could also, you know, be coercive. And this is not something that's happened in the US, to my understanding, but in the UK, there was a pay for performance scheme for LARC, which is essentially, you know, sort of incentives being provided to providers based on uptake of LARC. And so that's something that's happening at a policy level that is, you know, can create coercion at other levels of the system because there's an external incentive being provided. Obviously, policy constrains reproductive decision making in the US, and so things like the overturning of Roe v. Wade, you know, create an environment where people can't actually freely decide, make decisions about their reproduction, and so those, you know, that is inherently coercive policy that is ever present. It creates constraints that trickle down through all these levels of the model. And I also think that, again, I want to just come back that autonomy can also be, you know, promoted at the public policy level. For example, California now is doing guaranteed income pilot programs for pregnant people with the idea of focus on populations that are economically experiencing an economic inequality, which is often very racialized, to improve health. And really this facilitates people's autonomy, because if they are able to make a decision based on some constraints being removed, that then comes back to the decision that they really prefer most, that's less constrained. So, you know, I don't, folks may remember this. There were several articles about spikes in IUD use after the election, the 2016 presidential election. And I think this is a good example of thinking about how the sort of what's happening on a policy level may actually come in, you know, trickles down into people's individual decision making, or even what you may be seeing in a clinical environment. And so the you know, the fear of increased, I guess you could say, reproductive coercion, or the rolling back of reproductive freedoms, you know, may have motivated people to get an IUD, and that could be for a host of reasons. Maybe it's something that someone wanted that they just hadn't organized yet, and this was an impetus. Maybe it was something that someone didn't really want, but the overall constraints of their environment, what they perceived their environment to be, shifted, and then that actually encouraged them to make a decision that they wouldn't have otherwise. And so therefore, that's sort of broader context of coercion constrains their decision making, even if it is the thing that they ultimately have decided to freely do. It's happening in the context of constraints. And I think I wanted to share this because I think there's also sort of anecdotal evidence that this is happening again since the Dobbs decision, which which is very complicated. And I wanted to share this quote from my friend and colleague, Dr. Crystal Littlejohn, who's a sociologist who's at University of Oregon. And I just heard her say this the other day: we can't fight reproductive injustice with reproductive coercion. And I think bringing, thinking about this complicated environment where so many people really, their tools for reproductive autonomy are being reduced. And how do we offset that? Reproductive coercion isn't the answer. And I think that the idea that, we should be encouraging contraception among people whose abortion access is reduced, for example, it's really a sort of problematic starting place. We should be supporting them in accessing these tools should they want to, but the idea that maybe they should be really sort of promoted to use a LARC, for example, because they're not going to get an abortion, that's problematic because essentially it's taking an inherently coercive perspective when we take that person out of the decision-making matrix, out of the sort of considerations. And I think, again, we have to realize that people are making decisions in the context of increasing injustice, but that is something they need to be supported on versus steered towards. So I want to shift gears and talk a little bit about something called structural competency, which I think is a helpful framework for really guiding our thinking around autonomy and coercion. I think it's this framework emerged sort of as an antidote to the cultural competency framework that has really been very widely critiqued over the years. For me, structural competency is a helpful way to think about translating important values and ideas from reproductive justice into healthcare provision. So, you may be familiar with reproductive justice, but I will give you my 101. Rooted in human rights, reproductive justice is an intersectional feminist social movement theory and praxis. It emerged formally in 1994. It was conceived of by Black women in the US who did not see their lives represented in mainstream feminist rhetoric around individual reproductive choice and the singular focus on abortion access. In contrast, their communities were really constrained in choosing parenting owing to the deep-seated structural and social inequality that they faced, as well as facing tremendous difficulties in raising children with safety and dignity as a result. So at its core, reproductive justice is concerned with promoting the right to have children, to not have children, and to parent with dignity, as well as the right to sexual and bodily autonomy. There's a wonderful introduction to reproductive justice written by Loretta Ross, who is one of the founders of reproductive justice, and historian Ricky Solinger. And I like to share this quote from this book. We think of reproductive justice as an open source code that people have used to pursue fresh critical thinking regarding power and powerlessness. And so you may have heard the phrase justice is a verb, and I think it applies here. Reproductive justice is a verb. It's something that you must do, and you have to determine how to apply this open source code in your work. Structural competency for me is a way to use this open source code to really think about the clinical encounter and environment. One of my students and I wrote this article about applying structural competency to reproductive health a few years ago. And so structural competency is a framework developed by physician scholars that seeks to address the challenges around, around structural oppression, really, and to encourage healthcare professions to recognize, analyze, and intervene upon the structural factors that impact health disparities. So it includes 5 elements. The first, is it really is based on a recognition of how economic, physical, and socio-political forces impact clinical encounters. And so that's that first part, defining clinical interactions in structural terms. But I think in order to be able to define these interpersonal interactions in structural terms, you really have to have an understanding of how structures are affecting people's lives. And that's what I hope that I can help you help you on your journey with some of the research I'm going to present a little bit later. There's also the need to develop an extra clinical language of structure, and this is thinking about incorporating the structural analysis, but thinking about in terms of structural inequity and racism and how that affects sexual and reproductive health. For example, if you think about the very common example of teen pregnancy and the narrative that if you prevent teen pregnancy, you can prevent poverty and all the bad things in life. This analysis really locates pregnancy as the problem. Not that young people lack access to sex ed or contraceptive care, that there's a lack of material support for teen parents, or that that economic inequality is associated with teen pregnancy and later economic inequality and poverty. And really, does the pregnancy change that trajectory when it's so deep-seated in inequitable structures? Rearticulating cultural presentation in structural terms. I think the most apt example that comes up for me about this is maternal mortality. The CDC lists Black race as a risk factor for maternal mortality, but as Dr. Monica McLemore and Joya Kerr-Perry have written, there's nothing inherent about Black skin that increases risk except for overexposure to racism, interpersonal, internalized, and structural. Observing and imagining structural interventions is really thinking about, understanding the root causes of inequitable health outcomes. Once you understand that, you also understand that clinical interventions are often so downstream that they don't address those root causes. In some ways, this is just being able to envision and disrupt harmful mindsets, but there's also actions to actualize reproductive justice, being involved in policy. But that's, that can go beyond developing legislation and lobbying. For example, a Planned Parenthood Marmonte, which is a LARD affiliate based in California, was one of 18 signers of a letter demanding that the Fresno sheriff immediately end a partnership between ICE and the police department, which had facilitated detainment and deportation proceedings of over 100 people. And so this is an example of something that's really an issue of reproductive justice, right? This is very much an issue of being able of safety and of dignity and in parenting and building families, and, engaging in that was a policy effort that's maybe not directly related to the care that was being provided, but it's very much related to the people who are being served. And finally, developing structural humility and really, sort of trained ability to understand that there are limitations to this framework. There's limitations to structural competency, because even with this understanding and beginning of engagement in interventions, beyond a clinical environment, there's also the understanding of what is and what isn't feasible within healthcare, even health policy, right? Given the longstanding impacts of white supremacy and inequity in the U.S. So Madrigal versus Colgan was a civil rights class action lawsuit filed in the late 70s by 10 Mexican American women. It was filed against the Los Angeles County USC Medical Center for Involuntary or Forced Sterilization. And so I'm going to share a quote from the book Fertile Matters by Dr. Elena Gutierrez. Here she is describing and quoting the testimony of a former medical student who had trained under Dr. Colgan. Poor minority women in Los Angeles County were having too many babies, that this was placing a strain on society, and that it was socially desirable that the women be sterilized. And so, so the medical student is recounting the narratives she heard from Dr. Colgan, and you very much see that in this, in those the words that are in single quotes, that this is I think we could say this is a form of violence, forced sterilization, but it's really being justified by narratives about which people are having too many babies and the adverse effects of their childbearing. And so here you can see that there is a lack of a structural analysis, which is not surprising, but the fact is that these narratives, even though this was from this was happening in the 70s, that we sometimes still continue to see these narratives. So I am I feel that things have changed in the last 10 years, but at the same time, even if they are changing within, a reproductive healthcare environment among our community, that we still see these narratives about some people being valued as parents, as mothers in our society, and others not, and that that those values translate to policies, unfortunately still. And this is a screenshot and a quote from a video about the findings of the Contraceptive Choice Project, which I imagine that folks here might be familiar with, but this was a study in St. Louis that sought to examine the impact of providing no-cost LARC methods, but it also perpetuated the LARC first directive counseling approach where people were counseled in order of effectiveness of contraceptive methods versus their preferences or their interest in methods. And so they produced this video talking about the success of the project and all the unintended pregnancies and abortions that were prevented by the increase of participants using LARC methods. And so in this video, in a very dreamy voice, the narrator says, "Who knows what can happen when those pathways to education, work, and financial stability stay open? The possibilities are endless." And so the claim here is that, the pathways to a good life, right? One where you have education and work and financial stability, that those are being kept open by the decision to use a LARC method. And therefore the possibilities are endless as a result. And I have no doubt, as I've said, contraception, I've talked about it being as a tool for reproductive autonomy, and in a way we can think about all those things that I mentioned earlier in terms of the framework and the different levels around autonomy and coercion as tools, right? Contraception is a critically important tool, but an individual using contraception doesn't change their social conditions, right? That stand in the way of living their lives with dignity and security. And so I would love to take a few minutes to share some of my research that I'm hoping will illuminate some of the ways that structures are showing up for young people as they think about their desires around pregnancy. And so this is a analysis from a qualitative study I conducted around 2015, 2016. It has actually been published and it's available open access. If you search for the title, you should be able to get a link on PubMed for it. So if you're interested in reading it at your own pace, I hope you'll consider doing that. So the background for this study is it was really thinking about the idea of unintended pregnancy, how to improve its measurement, and particularly the idea of ambivalence in pregnancy intentions and what that actually looks like for young people. There is this traditional, in the research world, we call this the pregnancy planning paradigm narrative. And so there's this idea that if you plan your pregnancy, if you just wait, then your life will be better. Why do you want to prevent pregnancy? Then you can do those things, then you can disrupt the pathways that are standing in the way of education and financial security, et cetera, et cetera. But really what this, besides actually, maybe being a little bit inaccurate in terms of what the data say, there is this implication of the narrative that, any health and economic benefits of preventing unintended pregnancy are individual cisgender women's responsibility to obtain. And how do they obtain it? Through pregnancy planning and through the use of effective contraception. And so this study was conducted with, young people 18 to 29 because of, the significance of the period of emerging adulthood, which is actually considered a developmental period in its own right. Sometimes it's between ages 18 to 30, sometimes 18 to 25, depending who you ask. But it's really that sort of the transitional period between adolescence and adulthood that's marked by identity, exploration, self-focus, and feelings of possibility. And it's, typically when folks are starting to consider their desires around family, around pregnancy, or other ways of family building, and how they're starting to contemplate their potential life trajectories and put those in place, which reproduction and parenting are part of that. So given the really high social threshold for being prepared for pregnancy in terms of, having all the things that you should have in order to be a responsible person who is sort of, accepted in terms of being ready for pregnancy. It's really, it's important to think about this time period, especially, given the financial and housing instability that is frequently experienced by young adults. And given that, young emerging adults may not ever envision themselves as being able to have the resources necessary to successfully plan for a pregnancy. And this is really true for those emerging adults who are already impacted by structural inequity, like community violence, homelessness, housing or food insecurity, or barriers to educational professional opportunities. And so for these individuals, research suggests that this pregnancy planning paradigm may seem unattainable, or even irrelevant to their lived experiences. So, the data I'm going to share comes from a study that I did, with young couples. And so it was really looking at that interpersonal context and interpersonal interactions where people were making decisions about contraception and pregnancy. But it also had this aspect of thinking about structures and racism, et cetera, things that are really affecting the people who are part of the study and how they were envisioning their lives and their families. And so initially it focused on young Latino women and their male partners, but then we were able to expand it to other groups. And I just do want to note that these were all comprised of a cisgender woman and a cisgender man, which I might not necessarily do now if I was designing this study, but that was where I was 10, 12 years ago when I started envisioning this work. So that is an inherent limitation. And so what I'm going to share from you is data we collected. We did in-person interviews. They were individual interviews, but we interviewed both partners, same time, different rooms. And through that interview, we talked to people about their pregnancy desires, their plans, and their relationship context. But we also had this focus on measurement and understanding how people understood survey questions and how that aligned or didn't align with what we researchers thought they were measuring. And so they also did a little survey as part of the study. And we would, during the qualitative interview component, we would talk to them about their answers and learn more about why they were choosing certain answers. And so this is the sort of racial and ethnic breakdown of participants. Most of the sample identified with some racialized, minoritized group. And as I noted, there are more Latinx identified individuals by design because that was the group that the initial funding had focused on. 41% of our sample were already parenting, and they had really a range of educational attainment, which I think we sort of used as a proxy for class as we were trying to design the study. So one of the things that was interesting, we had put in a whole bunch of, not a whole bunch, we had maybe 10 to 12 existing survey questions that were getting at different aspects of pregnancy planning, intention, desires around when people wanted to start a family. And so one question we really dug into was this question about, if things were different in my life, I would love to have a baby. And so this question was part of a survey that the organization is now called Power to Decide. It used to be the National Campaign to Prevent Teen and Unplanned Pregnancy, but they had put this into a survey and asked people to strongly agree to strongly disagree with this statement. And so what they found is that most unmarried young adults wanted to be parents, but were ambivalent about the timing and circumstances under which to start a family. And so, so again, we were trying to understand ambivalence. And so we put this question in. And so they sort of define people as being ambivalent if they said that they wanted to be parents now, if things in their life were different, right? So what we found when we asked our participants this question, that we found that people were like all over the spectrum on this scale, which is interesting because they often tend to sort of, these are people who are not actively trying to get pregnant. So in a lot of the questions, the whole sample was pretty similar, but this one, there was, a big spread between strongly disagree to strongly agree. And so when we started asking people how they made sense of this question, it was not at all. I think their understanding of it was very different from what we, what we understood to be the sort of the researchers' understanding of this. And in fact, they weren't necessarily ambivalent. Some of them were, but it was really reflecting a tension between what their underlying desires were, and then what was actually possible in their lives given constraints. And we saw that this was really stratified by people's social advantage. And when I say that, I mean that we saw different patterns of what was happening with folks around this idea based on really the privilege that they were afforded, based on their economics or educational attainment. And so what we found is that there were sort of three groups of people in this study, and there were 50 couples in it, so 100 individuals participated in these interviews. And so there were folks who felt things will be different later, that they don't have everything that they need, and that they'll never have everything they need. So I'm going to describe each of these in the following slides, but really the important thing to note is that these, we call them typologies, they were distributed, like the way that they spread out in the study were really, we call it stratification, but really we saw different things based on people's economic and social advantage. And so I'm going to describe the spread of the participants as I talk about each of these. But overall, I will say that the men and women in the study appeared in the typology similarly. And, again, we had 50 couples in this study, and there were 11 couples where the two partners fell into different typologies. So first, things will be different later. This was, I think this was the one where most 52 participants were represented. And most of those participants were what we classified as socially advantaged. And so for these participants, pregnancy desires and plans really seem to center around economic, experiential, educational, and relational goals. And so, as well as what they perceive to be as the ideal age for parenting. And they largely describe feeling as though having children right now would be undesirable, though, they look forward to pregnancy later in their lives. And so while some of them experience feeling that they wanted a pregnancy now, if things were different in their life, going back to that original question, it wasn't really about things being different in their lives right now. It was reflecting things being different in their lives at a later stage, right? Things would be different because they would be older, they would have, they had personal expectations of achieving the milestones that they associated with being ready and prepared for pregnancy. For example, 124-year-old Asian woman reflected, like, if things were different in my life, if I was like 29, then I would be fine with having kids. Like if I was financially stable, or if I was older, or if I was married, or what it meant by different, then yeah, I'd be okay having kids. But like, I don't know, if like those things were different now, I'm still kind of young, so I wouldn't want to have kids even if I was like financially stable or married or whatever else it was. And really, this quote really just captures this, that, she's thinking about stability and marriage and et cetera as things that will be different later. And she even says, if those things were different now, I don't think it actually would change what I wanted. Similarly, a 22-year-old Latina woman noted, if things were different, I don't really want things to be different in my life right now. So that's why I put neither agree nor disagree. But if I wasn't like different in the sense that I would already be out of school and have a job, then yes. And so overall, people in this theme didn't desire things to be different now, but rather they envisioned a future in which they surely would be later, just by virtue of being further along a life path they already perceived themselves to be on. So they believed they could plan for a pregnancy in accordance with their desires, and that their plans could and would be actualized. And so for this group of people, contraceptive use, did seem to sort of more fit in that planning paradigm. Really, they thought of contraception as something that could help them achieve their goals, and they needed to postpone pregnancy to achieve those. So these assumptions that they were able to do that were reflected in their contraceptive use, with 67% using highly effective methods, 49% were using multiple methods. I will say that also that There were 8 people in the sample who were using withdrawal as their primary method, and they were actually all in this group. And so there we saw, there wasn't such a neat connection between their goals and their contraceptive use, because those were complicated. Their contraceptive access was complicating the connection between those two things. So the second theme was, I don't have everything I need. And this was, again, a pretty large portion. 39 of the 100 individuals fell into this group. And so their pregnancy plans were delayed due to lack of financial, structural, and social supports that they perceived to be necessary for pregnancy preparedness. And most of these participants were actually in the sort of less socially advantaged group. While these groups wanted to have kids earlier, they felt the need to delay pregnancy until they could contend with structural barriers. And so their pregnancy plans were actually shifted by way of structural inequity. They weren't in line with their true pregnancy desires. For example, this participant said, I think the bottom line, at least for me, has always been like being financially set. Being financially set gives you the freedom, I would say, to have a kid. I know there's a question that says, like, if things were different, would you be willing to have a kid now? And I said, absolutely. Because if I could have a kid now, man, without having to worry about, finances, that's definitely something that I would be more than willing to do. I'll be absolutely glad to do. And so this participant was really familiar with structural inequity, having paid many years of college tuition out of pocket due to his inability to access financial aid as an undocumented immigrant. While he would be happy to have a child now, his plans were actually at odds with his desires, as he feels that he has to delay this until financial resources are in place. Still, he expects that the barriers on the path to accumulating the necessary resources for childbearing are going to be overwhelming. I actually can't see my notes here on the screen, but I believe he said he had heard that it cost $1 million to raise a child over the course of their 18 years. Notably, one couple mentioned the difficulties associated with having a child in a society that provides little structural support for parents. These participants already were parenting, and they chose to delay having more children until they were financially stable to avoid experiencing increased hardship. And so this participant talks about, if there were a system in here, like in our society, that would let moms stay for the necessary amount of time to bond with their babies, instead of just like, oh, hey, go back to work kind of thing, I would love to have another baby. I just think a lot of reality just kind of like shapes whether I need to have a baby. I'm trying to word it correctly and try to word it so it makes sense, because I just feel like if the system was perfect and like there wasn't like so much stress on everybody, having a family wouldn't be a big problem. And so for this couple, the larger structural issues that just make it different to parent in the US while working or attending school strongly influenced their plans and what they were actually doing. And because of this lack of support, they were delaying pregnancy beyond their true desires. So for this group, contraceptive use looked a little different than for the first group. There was, this underlying tension between their desires around growing or starting their families through pregnancy, and then the need to wait. And this really complicated contraceptive decision-making. And unlike the early group, 44% of this group was using external condoms as their primary method of contraception. And one of the things that stood out is that in the earlier group, people's, the priority of their goals and plans made side effects more tolerable of contraception, whereas in this group, people really chose not to tolerate the side effects. And I think this is part of what's reflected in that tension between what they want and what they can actually have, and perhaps an underlying sort of acceptance of pregnancy, because that is actually reflecting their true desires. And finally, there's a group that it was only 9 people. However, in qualitative research, the numbers, aren't necessarily the most important thing, but the meanings and the impact of what people are saying. I just want to give a little warning that this is a very, these next few quotes are really difficult. And so if you want to put yourself on mute as they are talking about racialized violence, please feel free. So all the participants who were under this theme were less socially advantaged, and they were all people of color, with most of them identifying as Black. And they expressed significant doubt about whether they would ever have everything they should have to raise a child. And so in a way, this alignment of their pregnancy plans and their desires was not relevant. This traditional planning paradigm that really is leaning towards structural preparedness almost appeared inapplicable because they didn't believe in their lives. They didn't believe that their lives would be dramatically different in the future. And notably, most of these participants reported using condoms or not using any contraceptive methods. And so, for example, one 22-year-old Black woman said, like, I've never met anyone who was like, oh yeah, I was now prepared to have my baby, and oh, I had $1 billion saved up for his whole life. Like, word, nobody's saying shit like that. Like, people aren't like, oh, I hella wasn't ready when I had my baby. And so this participant describes that she actually never knew anyone who had all those resources that were perceived to be necessary to have a child when they got pregnant. Rather, they have a child and figure it out after the fact. And because she similarly doesn't anticipate having those resources, she doesn't feel the need to plan for pregnancy and feels accepting of a pregnancy no matter when it occurs. And therefore, this idea of pregnancy planning lacked relevance for her. Importantly, a couple participants described these major constraints to what they wanted in terms of pregnancy, not only due to financial instability, but also because of pervasive experiences of trauma, community violence, and systemic racism. So this participant says, it's not abnormal for a parent to bury their 12-year-old, 13-year-old son or daughter. Like, it's just not, it's normal where I'm at right now, like in this life, it's normal. So it's like, I'm kind of scared to bring a kid here. Yeah, I worry about your son getting murdered, your daughter getting murdered, your daughter getting molested or something. I gotta worry about too much, so it's kind of scary. And at the same time, you know, I wanna bring them into the world, but it's still kind of scary for they get older. I can't stop everything and everybody. And so for this participant, trauma and structural inequity he had experienced, including being incarcerated and losing many people that are important to him, made him scared to bring a child into the world. But also, you know, he didn't expect those circumstances to change anytime in that time soon. And in that way, you know, sort of he's accepting of a pregnancy despite the fact he can't control the world around him, saying that it would probably be the happiest moment in my life if he found out his partner was pregnant today. And so, as I said, it's like, you know, earlier, 44% of the participants under this theme were not using contraception. And when they talked about, you know, whatever they were using, nobody described prioritizing effectiveness for pregnancy prevention as being important in choosing their method. They also, you know, again, didn't talk about, you know, tolerating side effects, because in a way that there was just not this strong link between contraception and what they were thinking about in terms of pregnancy. And so that the whole idea of this planning paradigm is really not holding up. And for some, that it seemed like not using a contraceptive method actually reflected the acceptability of pregnancy, because even though they couldn't necessarily claim that that's what they wanted in a survey, that is what came out in the interviews when they talked about things being different in their lives. And so I wanted to just leave with a few takeaways about, you know, I think that these data, my hope is that they show how structural inequities are constraining the actualization of pregnancy desire, specifically in this period of emerging adulthood, and can really demonstrate how some of those structural constraints that we saw in those concentric circles I talked about earlier are playing out within relationships and within people's decision making around pregnancy and around contraception. And this whole thing about like planning, you know, it perpetuates this thing called stratified reproduction, which is really the valuing and devaluing of some people's reproduction through policies, through interactions, et cetera. And so for those people who had resources, those socially advantaged people, there was a normative timeline that they expected to, you know, they expected they would achieve their professional and educational goals. But those who didn't have that advantage. Structural constraints led to a delay in what, in making a connection between what they wanted and what they were actually doing, and they were just sort of making it work. And I think that this really, requires us to reframe how we think about health disparities, especially as they relate to unintended pregnancy and the connection between contraceptive use, because we see that, some of the differences in contraceptive use are really, are rooted in issues of inequality that are so salient in people's lives. And I just wanted to conclude by bringing us back to these slides about reproductive justice, because I think that in centering human rights, the reproductive justice framework really speaks to sort of the world that we hope to live in. And I think, it is a very hard time, but for me, centering this hope is really important in order to think about issues of injustice and coercion and how we can disrupt them. So I will stop sharing now. And I think we have a few minutes for discussion.
Yes, thank you, Dr. Gomez, for that informative presentation. As a reminder, you can ask a question by clicking on the Q&A feature and typing in your question. We do have a couple of questions already. Do you have comparison data for preparedness based among races and or divided of economic status? And does this theme stretch among all races or SES?
Yes, well, first I will say that I am of the philosophy around qualitative research that, even though I provided numbers, that's not really the most important thing about qualitative data. It's really thinking about the concepts that are coming out. And so I can say that, we didn't necessarily have a lot of white folks in the sample to begin with, so very hesitant to make claims, but I can just say that the socially disadvantaged groups really did reflect social disadvantage in our society, and they were more, they were disproportionately people of color, even within our very diverse sample. And so I think, the sort of pieces of how are we measuring social advantage were around things like housing security and economic security and educational opportunity. And so, again, we saw the sort of more privileged people that were in that first group about assuming that things will be different later.
Okay. I'm having trouble understanding how to navigate being funded by grants to provide sex ed with teaching through a less coercive lens. How to reconcile when a nonprofit needs grant funding, but they perpetuate this problematic lens.
I missed, what was the word before lens? I mean, the first one.
Oh, the first one?
Yeah.
Sorry, less coercive lens.
Oh, less coercive lens. Okay, so first of all, I want to just say that I really feel this, dynamic, because I know that often if you can't provide the education or services without funding, then right, it means that the people aren't going to get them. And so I hear you. I think one thing is, so I think within organizations, if there are ways to sort of de-emphasize the importance of those metrics. And so I think one of the things is sort of adopting a philosophy of thinking about, this is something we have to do in order to get this funding. And really, I mentioned earlier the provider from New Jersey who was really complaining about the requirements of the Title X program. And, and something she just said was that I really just, try to do this as discreetly as possible in terms of collecting these data, because I don't actually agree with it and I don't want it to affect my relationships with my patients. But I unfortunately am required to do that. I think that this then also speaks to the need of, this is something that maybe at an organization level you're experienced, but it's coming down from policies and higher levels. And so I think that really speaks to the importance of trying to change what is a good metric and what is valued. And so that's something I'm trying to do through my work and with others in the field in terms of really trying to reframe, you know, what is a good outcome, for example, or what is a metric of quality. And I think that those changes have to happen at a systems level. And so I know, at least for the clinical environment, I think there's some stuff that's happening with the Office of Population Affairs, and I hope that that will actually be the potential for more measures that are actually focused on advancing autonomy. And I think for private funders that we actually need to push them to do the same. And so I know that doesn't help you in your day-to-day work, but I do think that that sort of reflects the need for systems change. And it's very hard dynamic when you're a grantee to do that, but I think there is an appetite for that. And so I'd love to talk to anyone who's interested in this topic. So.
Okay, you have also a statement. Wow, thank you for your amazing work. You have helped me think about and understand reproductive justice in new and meaningful ways. And then a two-part question. You stated for your young couple study, you may have done it different. Do you have plans to conduct another one? And do you think, or would you be surprised if it yielded different results?
So I don't have plans to connect, but I will say that it's very, there are a lot of challenges to doing research with couples, just in terms of, you know, trying to get two people to sign on to a research study. And what we were doing is we were actually having them come in person to do interviews. So things have changed a lot just in terms of technology. And so it might be a little bit easier. I was actually just thinking more about, when I say I would do it differently, I do think it had a very, just very, you know, sort of centering cisgender people and their relationships. And I honestly don't know that things would have changed, things would that change in terms of the findings we you know, conclusions. I don't know that things would be that different if I did the study today, but I think for me that I would, you know, want to really think about how to be more inclusive, because I think, you know, we really sort of focused on racialized groups and the inequality they were facing, but I think adding the layer of oppression that queer and trans people face would only intensify these issues. And so that's what I was thinking about when I said I would maybe do it differently, you know, if I was doing it again.
Thank you for that. Would you please speak about the impact of crisis pregnancy centers on the reproductive justice landscape?
Oh my gosh. Well, this is not my area of expertise, but I can say, in my view, crisis pregnancy centers are facilitating reproductive coercion at all levels of the framework, especially in that, you know, from the policy landscape, if government dollars are going towards supporting crisis pregnancy centers rather than reproductive health centers, if they're settings that are not providing full options, counseling to people, and even providing mis and disinformation. I mean, I think that in every way they are, you know, facilitating coercion, frankly, in my view. And I think that's only increasing in terms of the reduction, especially in states that are, you know, where abortion access has become extremely restricted or non-existent. That I think of things like contraception, abortion. I also, you know, even paid family leave. I think of these as all tools for reproductive autonomy. But I think, you know, and so in our toolkit, you know, we have things that are becoming less accessible, and it, you know, requires work to make it more accessible and to increase the strength of those tools. And I think of crisis pregnancy centers as a tool for reproductive coercion. And so so I mean, I don't know if I said it specific enough, but I really do see that the greater prominence of them is something that is facilitating coercion. So.
Thank you. You mentioned Sister Song as a premier organization. Are there organizations or tools that clinics can utilize to improve our work and move from a reproductive health framework to a reproductive justice framework?
I think this is, I I think that we hear a lot about sort of reproductive justice in the clinical space, but I don't know necessarily that there are a lot of tools out there yet. I do know, so in terms of performance measures, for example, I know that there is a person-centered measure of contraceptive care that's been implemented by the National Quality Forum. And so, so that's way one thing in terms of just shifting what we're looking at and the data towards a more person-centered approach that really is about centering people's humanity, which I think is an essential component of justice in a clinical setting. The UCSF, I believe it's called Innovate for Education. There's a course on structures and self and reproductive health, which is developed by Dr. Zoe Julian, who I believe is an OBGYN. I think that is actually sort of a curriculum that's something that people can access right away for free in terms of that work. And I think, I'm still looking for the sort of model clinical settings that are doing this and that are providing examples. And I just have to say that I think there are places that are doing it, but it's really sort of disparate information. And I hope that we can sort of start to uplift those more in order to provide examples for settings to follow. Because I think changing settings is something that we can do in some ways when they're not constrained by funders, et cetera,
Okay. You are making amazing contributions to our field. What are you working on now or next?
Okay, so I usually am working on way too many things, but the two projects I currently have going on, one is actually a focus on developing person-centered measures of contraceptive access. And so it is speaking to some of the things that folks brought up earlier about, about some of the measures that we have to collect and report to justify funding as being coercive. And so we're really trying to advance person-centered measures, thinking about not at a population level if people are using contraception as being a good thing, but are they using a method they want? Do they have access to the method they want? Someone using a method may need to stop using it. That means they have an access issue. So that's one way we're going about it, but we're also thinking about people's informational needs, et cetera. And so we have some great national data that we're working on publishing and trying to think about how to actually get those values implemented and measures. And then the other main project I'm working on is sort of related. I shared a slide about the guaranteed income programs in California, but I'm working on a program that provides Black and Pacific Islander pregnant people $1,000 a month. In San Francisco, these are the two groups that are at greatest risk of preterm birth. And so really thinking about addressing racialized economic inequality during this really sensitive period to hopefully promote reduce stress and promote better birth outcomes. And really, it's not changing the structures, but it is trying to be responsive to structural racism and the economic inequality that's wrought. So those are my main two things.
Very exciting. Okay, I'm just going to give another 15 seconds to see if there's any other questions. What can voters do to support a reproductive justice structure in the United States?
Well, I mean, I think they can vote. That is unfortunately just showing up is one important thing, because even though we've had greater turnout in our more recent elections than we've ever had, it still really only is, it's not, we can't say it's the vast majority of people in the US vote. I think that I think it really depends on your state. There were in the midterms, we saw some ballot measures that were actually, promoting in reproductive freedom and actually, putting it, for example, in the California state constitution. We saw in Kentucky that there was a ballot measure that would have constrained reproductive freedom that was shut down. And I think that really showing up is important. I think, so much of our power as voters has been reduced by decisions by the Supreme Court, by gerrymandering. And so I think not only showing up to vote, but being active in policy and, getting others to come to vote are really important, because I think that unfortunately the odds are against, the numbers are against us because of the way voting rights have been rolled back in the US. And so I think that showing up is great. And I'm really, really excited that young people are shifting the tide. And so I think if you're working with young people, if you have young people in your life, to really think about how we can support them as the change makers and in continued civic engagement, because we have a long battle ahead of us with lifetime Supreme Court appointments. And so that's, I think that those are things off the top of my head as a non-expert on voting to support reproductive justice. So.
Well, that concludes our questions. Thank you, Dr. Gomez. That was amazing. We will start our next session with Dr. Ina Park at 10:30. Please use the Zoom link found in the agenda to connect, and we look forward to seeing everyone soon. Thank you.
Thanks everyone for coming.